presentation at the meeting about iron trafficking. Sounds like something in a drug world, right? Iron traffic genes. So in some of us, of course, we have things like hemochromatosis. And you can check the genetic type of your hemochromatosis. And we found that there was a strong correlation between some subtypes. One subtype, if you had both of the genes for it, okay, you had quite a high risk of primary progressive MS. Another subtype, you had an increased risk of secondary progressive, not quite as dramatic. So I would suggest this is an even more critical issue for those of us with severe disease. The more severe the disease, the more likely this may have some impact. Every time I give one of these talks, a few people come up to me or email me after saying they've got both. Well, we're going to learn a lot about this in the near future, and it could be a significant piece of the puzzle, and it seems to happen in the other neurodegenerative diseases too. Excess iron in the brain. Think about it. Iron outside the blood vessels is an injury problem. You get a bleed into your knee joint or your elbow joint, hurts like crazy. The iron breaks down. It oxidizes. It creates free radicals. Literally, you're rusting in that joint. Well, the back pressure of the veins and the blood in the brain is felt to leak through the blood-brain barrier, deposit red blood cells, which of course contain iron, and that's where the excess starts from. Once the iron is released from the hemoglobin, it becomes free iron, which oxidizes, or as you know it, rusts. So, rusty head syndrome is a new term. I don't know if it's going to catch on, but it might be something to it. So that's what we've talked about there in the different types of hemochromatosis in some 400 patients that they looked at. That's quite striking, you know. So 23.3% of those folks with primary progressive had one particular type of the genes of hemochromatosis. That's quite a strong association. So there's going to be a lot more work done on this, needs to be done. Okay, the incidence of CCSVI normals, this is the one that got us to that 7.5%. So the one pink fellow or pink woman, they happen to have CCSVI. However, it's different in those of us with MS, so this is exactly what I talked about. We thought it was about 20%, but a lot of those people were from MS families. So it was a skewed report. Okay. I talked about a little bit about vascular dementia already. Most of us heard the report the other night on television, Ralph Klein, with this. If Ralph is a wise man at all, or the people around him, he should be checked for CCSVI immediately. He could maybe have a profound benefit. Can't guarantee it, but I know it won't hurt anything. This is a safe procedure, and it could make a profound difference. We have never had anything that would do that before. Okay. So this is a prospective analysis. Everybody's been saying, well, give us, you know, a prospective trial, because a prospective trial is always better than looking at what happened, so-called retrospective trial. So this one was reported, it was by Dr. Maida at the Albany Medical College, and he looked at 150 patients over a period of time. He evaluated them with the 3 different tests. One was the quality of life score, which has got a mental and a physical component, and one was the modified fatigue impact scale, and he looked at them at 3, 6, and 12 months. So obviously that took more than a year to do that study in 150 patients. There's at least 5 prospective trials, some of them double-blind controlled, although I'm not sure that's really possible, in the US right now. They're doing 650 people in Italy, and they're doing 100 or more in Britain. Why aren't we doing them here? I have no idea. Okay, the association's there. So, in his 150 trial, we found, next slide. So, first of all, looking at stenosis. Typically saying whether you've got narrowing there is if it's more than 50%. So 150 patients, 267 narrowings. Most people had 2 or sometimes 3 narrowings, okay? And that's why that number is bigger than 150. 90% of those narrowings were the internal jugular veins, okay? And 10% were in the azygos vein. When I had my treatment, I had both jugulars narrowed, and I also had narrowing across the arch of the azygos vein, which is present in about 70%. Wasn't out of this study. The other thing they looked at over the period of, so they treated them, they were able to improve to less than 20% stenosis in 77% of patients. But this is more than a year ago, this study. Therefore, they didn't know about the concept of treating the valves properly. Okay? The valves is an issue in the jugular veins, and at least 80% of us was CCSVI. 80%. And if you don't treat the valves, lots of the other stenoses are hard to treat. In fact, reality is most of the other stenoses up the jugular vein disappear when you treat the valves. So it's an upside in two ways. First of all, you treat the valves, you get a more complete treatment. Secondly, you don't have to do those interventions up higher, and you're probably going to get less stenosis. In his study, the restenosis at 4 months needing reintervention was 9%. So far cry from the 50 we've talked about before. And then in the physical quality of life, they went from a score of 40 to a score of 59. So a dramatic improvement of the physical quality of life. So with a very high p-value, meaning it was very statistically significant. The same with the mental score, quality of life, they went from 52 up to 70. So a profound improvement there as well. And then they did the fatigue score, and the fatigue was reduced from an overall average of 15.8 to 12.2. Again, extremely significant statistically. The EDSS, which hasn't been affected one iota by the drugs either, frankly, is a very crude test. It will take time, and it will take a lot of rehab. I suspect if you do enough rehab after your treatment, you'll probably improve your EDSS. Some of us are lucky it improves overnight, but it's too crowed a score to hang your hat on. And if your neurologist says, show me improved EDSS scores, then put them back onto, well, you're skating on thin ice, sir or madam, because after 10 years of the crab drugs, you guys know them, Paxil, Rebif, Avonex, and thank you, beta-serine, the B. I was moving into D. I still need some rehab on it. So, you know, after 10 years of trials, 3 reviews have shown they don't really work. Now, they did have one statement in Italy about the interferons. They may be helping some with the leak of the blood-brain barrier, okay? So, you can take whichever spin you want on that. My personal spin is follow one path and ignore the expensive drug one. Okay. So, that's where we are today. I would suggest you think about it early. Get onto it. We've got great places to go. I applaud those that went early. And you heard some of the people today admit they had early treatment, they needed a second treatment. Less of us will need the second treatment because things have improved in the last 6 months. I'm grateful, by more luck than anything else, I happened to go to a center that was right up to date on the newest treatment of expanding the valves. I think that's exquisitely important. We need to educate our family docs. The neurologists will take their time. We need to have the family docs realize, and the public realize, through information through one another, there's other people know about the brain other than neurologists. Okay? We've got interventional radiologists know the brain, neurosurgeons know the brain, and anesthesiologists do know the brain. All right? So, if one group is stuck, then maybe we need to move to the other groups, or we need to get the other groups on side. There's a couple of things to clear up. There's been misnomers out there, but you've had a superb talk about stints and the superior vena cava syndrome. Many of you will have watched Dr. Rubin's presentation that was done in Toronto some 6-8 weeks ago. It's 2 hours, it's hard to watch, but I felt I better get through it. I mean, he said, if this existed, everybody would be like the superior vena cava syndrome. That's where your eyes almost bulge out and you've got big swelling of your veins in the back of your eye, which happened in the case that Joseph showed you, of where there was backup because complete blockage of the vena cava, nearly complete, from a cancer, right? But that is acute blockage. Our blockage has happened over decades, and it's different. It's a chronic problem, it's not an acute problem. And he should have understood that if he looked at the literature well enough. And he's on the Ontario committee now, and he's a vascular surgeon. But, you know, I spoke with Sandy McDonald, who's a vascular surgeon based in Barrie, Ontario. Bright guy, very keen, does ultrasound down there, has a major clinic on it in Barrie. $250 a crack, not unreasonable. And anyway, Dr. Rubin is not cutting it. That's the short story. So we need to continue to dispel these things. Coming back, no follow-up. There's not many injuries possible from this. Yes, some of us, our vein will clot in the jugular vein when we get home. Not as many as was. They're using Pradax, which is what it's called in Canada. In the US, it's called Pradaxa. It's a drug that works a little like warfarin, although it isn't as easily reversed. And so often people are on that 2 weeks. But some of us will clot that small vein, especially if we had a small vein, we've opened it up, and maybe it's not flowing well enough. All you're going to do is wait, watch, and see. Because if you're fortunate, that vein will reopen up. But remember, usually we've treated at least 2, but usually 3 veins. It's the total blood flow getting out of the brain that matters overall. Consequently, if we can keep it improved in the other ones, whether that one changes or not, it's not a game changer. Most of us will stay reasonable. You will do a small amount of helping prevent that clotting if you're truly taking enough fish oil, because that has some degree of difference on it as well. But also, you want to minimize the restenosis. So you can find that. You can find it at Synergy, because now they use my so-called recommendations. It's time to go back to pen to paper. I brought along some of my MS books today. If people want them, I'd be more than happy to sign them for them. It'll help pay for my trip out, I'll be honest. But, you know, it's time to go back, and I hope to have out this spring one with a couple of chapters on CCSVI and a chapter on low-dose naltrexone. We're not here today to talk about that, but it's another piece of the puzzle that some of us need. Okay? So I think from there, and I want you to continue to follow on where you'll see it, nationalccsvisociety.org, which is on the bookmark that you maybe got today, because that's where things are posted. You'll click on education, and then you'll click on NCS Library. In fact, we're redoing our website. We've happily teamed up with Alberta CCSVI. It will be our first chapter, and we're very keen to work together. I'll be back again in the late summer or fall to speak with what's new and what's changed and what's happening, because there's lots moving forward. Next year's International Society of Neurovascular Disease will have a day for clients or patients. It's in Florida. If you want to write it on your calendar, I think it's the 18th to the 22nd of February. There's worse times to be in Florida if you live in the prairies. So, and I've been asked, along with the chairman of the CCSVI Alliance, which is the American version, you know, to put together that scientific day to present to lay people. Knowledge is power, folks. We're here today because of the connection of us together working this forward. It's going to be pushed back from the people. We're not going to get led forward in this by, you know, the subset of people who are denying it. You've got lots of people knowledgeable on it now. The vascular and interventional radiologists are light years ahead of these other guys, and they're going to be a while catching up. But we've got good people, we've got good support, and in the short term, we're going to have to go south of the 49. But at least we've got good places to go there, and we don't have to go somewhere where the knowledge is a challenge and it's hard to interact. So I think we're going to throw it open for questions there now. Thanks very much.